Hello, everyone. My name's Raheel. I'm a core surgical trainee in orthopedics in Birmingham. And today I'll be talking to you about the trauma system in England. It's a brief literature review, just going through the current system, the historic system, and just identifying some of the challenges and insufficiencies and future recommendations. This review was done with my colleagues over at the Queen Elizabeth Hospital in Birmingham, Royal Stoke Hospital, and the Royal London Hospital as well. So I have no disclosures, none to declare. So as we all know, trauma is a huge part of what we see and the patients that present to us in the hospitals and our clinics. And essentially trauma is a disease and is defined as physical injury to the patient. Major trauma is a dynamic public health epidemic. It's continuously evolving. So the NHS trauma system is quite intense in terms of includes many different levels of care. There's pre-hospital critical care teams, major trauma centres, trauma units and rehabilitation facilities, which all form part of the structure to deliver a good trauma care. These rely on multidisciplinary team input and they formalise the structure. And as I said in this review, we'll be looking at some of the insufficiencies and how we're going to recommend strategies for enhancements. This will be valuable for policymakers, healthcare professionals, and researchers in the field of trauma care. So just a few pictures I thought would make it a bit more fun. That MIST is a major incident surgical and trauma teams network all over the country. They're quite heavily involved in major trauma centres. They'll have colleagues all over. They do run courses just to improve the awareness and knowledge of trauma around the country. So as you can see here, this is the whole map of the United Kingdom, besides Northern Ireland. And this basically covers all of the trauma centres in the UK. I work here, Queen Elizabeth Hospital in Birmingham. And as you can see, they're quite widely spaced across the country to give a good exposure and adequate network all over the country for major trauma. So what does trauma care actually involve? Obviously an ambulance, pre-hospital critical care teams that include paramedics, intensive care doctors, people who know how to do intubations, quite heavily trained people. And when the patient comes to the hospital, emergency care physicians are there, anaesthetists, if the trauma call is activated, will get you an anaesthetist, probably an intensivist. You'll get the orthopedic surgeons, you'll get general surgery, and you may get, in some trusts, it collects data on trauma all over the country, and it all goes into TARMS, the Trauma Audit and Research Network. Trauma is a leading cause of death in children and adults under the age of 44 years in England. And in 2010, the National Audit Office reported that over 20,000 cases of trauma annually in England with over 5,000 deaths. Now that's a bit outdated. We're still waiting for more updated figures from the National Audit Office. Further studies have been done, which basically all show that trauma is quite a heavy burden on mortality. So let's talk about some of the historical improvements of the English trauma system. It's made a step change after several reports identified insufficiencies between 1988 and 2009. There were reports from the Royal College of Surgeons, the British Orthopaedic Association, the National Audit Office, TARN, and the Department of Health. Before the introduction of a trauma network, there was uncoordinated trauma care, there's a delay in response time, and trauma patients weren't really prioritized in terms of a structured care support network for them. In 2012, after these reports, national major decades of suboptimal trauma care. Lord Darcy described how the English trauma system endorsed pre-hospital critical care teams to bypass general hospitals and determine appropriate transfer to either major trauma centre or trauma unit. Major trauma centres have led to an increase of 20% in the chances of survival and trauma in the British population, with an additional 500 additional survivors and 3,000 trauma patients treated per annum. So what do we have now? We have 27 major trauma centres across England in proximity with trauma units, and they cover approximately a population of 56.223 million. The London Air Ambulance was actually the first pre-hospital critical care team in the world to use a REBOA, which is a resuscitated endovascular balloon occlusion of the aorta. A brief breakdown. So there's 11 centers with adults and children, 10 with adults only, 5 with children, and 1 group of hospitals which function as a major trauma center. So the review involved a thorough literature search of the Medline database from 2003 to 2023. It's conducted to collect relevant information of the English trauma system. Relevant articles and study were analysed to extract information on the English trauma system, to analyse the structure, challenge, potential areas for improvement, and a critical appraisal was done of this literature. So what did we find? There are different types of trauma scoring systems. You have major trauma patients, but how are you going to categorize them as severe or not severe? Anatomical trauma scoring systems include the abbreviated injury score, the injury severity score, which is one of the most commonly used ones, and a new injury severity score, physiological, pediatric trauma score, revised trauma score, and the Apache score, and combined is the TRIS and the Kampala trauma score. So, looking at some of the insufficiencies, the injury severity score actually has a threshold of 15, not max, but that's kind of a cutoff, which is generally expected, that defines major trauma and activation of trauma teams. It's calculated using the squared sum of the 3 highest abbreviated injury scores, and it predicts solitary end mortality. But there is a deficit. A large group of patients are actually omitted with a low probability of mortality, but higher chances of long-term disability to morbidity. There's a study with Palmer et al. Which rationalized suitable outcomes to measure would be to include both morbidity and mortality, which would lead to lower ISS thresholds. So basically what I'm trying to say is, if there's a patient with an ISS of 15, but we've only calculated that based on the 3 highest AIS scores, we may be catching all the patients with severe injuries, but we may not be catching the patients who have injuries, but their long-term disability and morbidity can lead to mortality as well. So we can upgrade ISS to reflect this, but this will involve changing the way TARN collects data. This will help avoid excluding large patient data sets with low mortality but high morbidity indexes. Another issue with AS and ISS is that pre-hospital critical care teams can't actually use them to categorize patients because they don't have imaging on the roadside or in a mountain or a hill. Triage is dependent on abnormal physiology, utilizing limited diagnostic equipment, which impacts the destination transfer of the patient. So some of the recommendations would involve introducing greater access to portable diagnostic devices, such as ultrasound, blood gas analyzers in the pre-hospital setting, and improve injury recognition by first responders in triaging patients to an appropriate trauma care destination. This may lead to higher costs in supplying pre-hospital teams with this training and equipment. A revised new injury severity score, which actually looks at the 3 severest abbreviations, help calculate an improved predictor survival compared to ISS. Implementing the new injury severity score to English trauma system is a challenging task. As I said, we have to restructure the way data is collected and submitted into TARN. Major trauma pathways and protocols will have to be reviewed to calculate cost-benefit analysis ratios to determine is there actually even a difference if we change from ISS to NISS. And further research in England needs to be tailored to compare ISS with NISS and what the outcomes of that would actually entail. This is from the Mater Hospital in Ireland. So silver trauma is actually a huge population presentation in major trauma centers. What does that mean? It's trauma for patients with the age of 65 or above. And that doesn't necessarily have to be high injury trauma. From standing, or they're trying to get out of the house, or they're trying to walk to the shops and they've tripped. And it's very important that we treat, but do we actually know what else is going on? So this is a nice kind of chart which looks at the mechanism of injury, which is extremely important, the physiology and anatomy, medications the patients are on, and ideally a trauma team should be called for any patient with trauma in this age group. So according to the cutoff there, but according to TARN, the commonly presenting trauma patient is no longer a young person on a motorbike doing some stunts. It's actually an elderly patient sustaining injuries from a fall of less than 2 meters. The mechanism of injury is extremely important in triage tools, and it helps surgeons, doctors, everyone in the healthcare professional system to basically identify how severe this injury may be. There's a growing population with a rising life expectancy, and elderly patients being exposed to more trauma. Especially with the cost of living crisis, people are doing more DIY at home, they're painting their houses, they're falling down, and we're getting a lot of these elderly patients coming in with multiple comorbidities and a potential poor outcome with higher mortality rates. Due to the introduction of trauma systems and a lack of injury recognition, not all elderly patients may actually end up in the right place. Some may be discharged, some may end up in a trauma unit, some may end up under the wrong team, and some may never make it to a major trauma center. And there sometimes is unfortunately a predisposition of ageism when assessing elderly trauma patients, leading to suboptimal care. Elderly trauma demands complex social care and a great emphasis on rehabilitation. Repatriation to trauma units from major trauma centers can propose discharge delays with bed blocking, and that causes a whole other issue, especially with these patients staying in hospital. They have a high risk of hospital-acquired infections and chest infections, urine infections, etc. How can we change this? Well, one idea may be to introduce separate major trauma guidelines for high energy end up being there. There needs to be a continuous involvement of geriatricians and ortho geriatricians in as well. Further research needs to be performed. There's a gap between communications with MTCs and trauma units. Patients end up being stuck in one or the other, and trying to get them across to the other side all depends on the whole structure of the system. Priorities need to involve increasing funding to trauma hospitals for the number of beds and promoting review of current rehabilitation pathways. Feasibility studies will help determine financial burden, comparing the length of stay in a hospital versus efficient transfer of patients to rehabilitation units from trauma centers. And resources will have to be allocated appropriately to increase the number of available community and specialist rehabilitation beds to compete with rising elderly trauma. They've broken their hip, they're unwell, now you fix them, they're better. Where are you going to send them? They can't go home. No one's there to take care of them. So we need to have more beds in rehabilitation centers to help care for these patients. Looking at the, so this is the London Air Ambulance, this is the HEMS helicopter, this is the West Midlands Merit team, just a bit pictures to show how trauma teams actually look like. Physician-led pre-hospital critical care teams are key to improve trauma survival. Critical care treatment must be delivered within the first hour, which is known as the golden hour. There's a shortfall of availability of physician-led teams to staff shortages and funding pressures, and London's the only regional trauma network with 24-hour coverage. NICE recommends anesthesia within 45 minutes in emergency call for major trauma patients. And there's a cohort study done in 2020 showed only 25% of patients with a median time of pre-hospital anesthesia have actually at 55 minutes. Overnight trauma cases are even higher, and there's less people on site to actually do something about it. So I'm just going to quickly breeze, I think time's up, but recommendations are we increase funding, more opportunities for pre-hospital critical care teams, increase education and awareness, more research, more studies, observation cohort studies. We need to basically grasp the effect of this issue and kind of put it into the research literature that this is what we have. This is a feasibility study we can do to make this issue better. And unfortunately, there will always be a high financial burden and cost because of this. In conclusion, trauma is a disease which is continuing to rise with changing demographics. England has an aging population with comorbidities, which correlates with the dynamic nature of trauma. The English trauma system has improved compared to 20 years ago, but it still needs further improvements. We need to review the current challenges, prioritizing resources. Geriatricians need to be involved in silver trauma care. Further emphasis on pre-hospital critical care teams and standardized, safe rehabilitation pathways with good communication need to be involved with a consistent review of the trauma system. Those are the references. Thank you. Any questions?